There we go. Andrea?
Yes.
Oh, okay.
Okay. So on June 22nd, the Children's Medicaid Redesign Subcommittee Advisory Group met. There was a very robust agenda. It's on slide 2. I'm going to go through the slides pretty quickly. On slide 3, it was reiterated that the 1115 waiver was submitted to CMS on May 9th. On slide 4, there's some new news. I think most people are aware of this, but they have decided to merge the OPWDD Care at Home waiver into our waiver transition under 1115. So you all knew that we were doing DOH Katie Beckett Care at Home into the one waiver. We're doing the OMH waiver, doing the B2H waiver. Now they are including the OPWDD Care at Home waiver. And I looked up on the OPWDD website. The Children's Coalition does have about 5 agencies that are listed as OPWDD Care at Home waiver providers. So at some point we may ask those 5 providers to do a presentation to the general membership, you know, how we have guest speakers, to do like a panel presentation about that waiver to our membership, just so that people can get more familiar. And then the only other change that was included is that the residential youth facilities licensed under OASAS, will remain carved out and will transition at a later date, just as RTFs and community residents as well. So on slide 5, we see what most of you have seen, the new time frames that are the dates that have been proposed to CMS. So whenever the negotiations start, there's a set of proposed dates. As the negotiations drag on, those dates can change. The fact of the matter is that the state now wants to implement the children's changes all at once. They're not going to divide it between upstate and downstate. And so the target, the target dates are basically July 2018. Jackie, I'm just gonna, we'll share this slide. I think Nicole sent everything out, so I'm gonna go down, rather than go through these details, to slide number 9. It's a chart that shows all of the steps that need to be taken before a child can receive services under the 1115 waiver. And if you see the 6 blue teardrops on the bottom, the base activities, you will see that we're not terribly far along in implementing these changes. We need to get federal approval. We need to promulgate state regulations, which we learned at this meeting will have to happen before any designations can occur. And so the target date for promulgating the regulations that would allow the state agency's authority to designate you as 1115 and SPA providers will be promulgated. The target date is October 2017. So we'll be keeping our eyes out for those proposed regulations and providing comment and collecting comments from you. The plan, so, then rates will be released and provider designation will actually occur. You can apply now, but the designation won't happen and can't happen until after the authority is vested in the state agencies. And the plan qualification negotiations are underway, so they submitted the plan qualifications. There were a lot of comments received. They're hoping to act on starting to approve plans this summer. And there has to be a determination about an independent entity. So as you know, currently, when we deem kids eligible for services, it's done two different ways for two different programs. It's done through the PAC process for RTF. It's done through the SPOA and the local government entities for home and community-based waiver. So there needs to be a determination about how those deeming decisions will be made. And then the steps after that you see are, engaging families and children to letting people know that the changes are coming, rolling out a new phase of CTAC and MTAC training for providers, continuing to inform and train the health homes and the care management agencies about the new services, and working with the plans to ensure adequate network development. On that point, at the kids MRT meeting, I did ask whether, given the fact that there really are insufficient providers currently, and we're going to be expanding the eligible population, is the state considering, kind of any willing provider designation? And they don't like to use that term. So what Gary Weisskopf responded was that they are considering designating anyone who gets designated as just a children's provider as an essential provider. And that would give you status that would require plans to contract with you. The alternative to that is the traditional at least 2 of the providers available in the region. And many people at the children's MRT meeting preferred the first method as opposed to the second. So I'm going to stop there and just ask Nicole, Nicole, are there any questions so far?
I haven't gotten any yet, but folks are welcome to raise their hand and I can unmute you, or you can put your questions into the question or chat box. Does anyone have any? Oh.
Nicole, can you hear me?
I can. I left you unmuted, Jim.
Okay, so I'm having trouble typing in questions, so I'm wondering if other people are as well, or is it just me? So if you've been getting questions, then it's just me. If not, then it could be a system issue.
Okay.
All right. But we will unmute phones, so if people can raise their hands, if that function works, we can do it that way.
Yes.
Great.
Okay. I'm not seeing any hands raised, but we did have a couple people who had said that they could hear you in the beginning. So I think it was working for a couple folks, but I think typing questions. Steve Bolster says, I think typing questions is working well on my end. That's the only question I have, so I think that's it.
And so then the last steps are making sure that kids are enrolled, that the eligibility processes are working well, that the plans are enrolling our providers and the kids, the new kids that will be eligible to be enrolled into plans, and that we align the new services with the new HCBS services. So this slide, I think, is kind of a very clear glide path to where we want to go. And I just want to reiterate what Jim said in his introduction. A very clear message from the state. It is the Department of Health's job. It is the Office of Mental Health's job. It is CMS's job to approve or negotiate the conditions of this waiver. And that's what they're focused on. They're going to get it done. One way or the other, terms and conditions around transitioning the 1915C waiver to the 1115 waiver is the goal. Now, what happens with Medicaid reimbursement can change the implementation, but people are just going to put their heads down and work to implement. And I think that that needs to be understood by the field, because there is not going to be any deviation off of negotiating the transition of the old waiver programs into the 1115 waiver or negotiating the SPA services. And again, What happens with Medicaid reimbursement will determine how that gets implemented. All right, so we'll skip slide 10. We'll skip slide 11. You know, you guys will get this PowerPoint. I just want to make sure that we, on 12, you see the focus of the feedback that went in on the plan qualifications. There was a little bit of a discussion about not overemphasizing how much personnel the plans have to have that are familiar with children's behavioral health. We want them to be familiar, but what's happening, the phenomenon is that they're hiring up the child psychiatrist to work for the plans, which is hurting us because we can't compete with those jobs. So, you know, we may need to be working with Department of Health and the plans to figure out a way to, you know, we can't have the psychiatrists working part-time for us and part-time for the plans, approving the services that they're authorizing. That's not going to work. So that was an issue that was raised at the MRT.
Yeah, and even more so than that, not being available to work for us because they prefer working for the plans.
Mm-hmm. So what are the minimum qualifications for, you know, oversight and approval? You want people who are qualified, but you don't necessarily want it to have to always be the child psychiatrist level. You know, the physician level, the physicians who have been trained by OMH through TEACH and about mild to moderate behavioral health. I don't know. I mean, I'm not going to offer a suggestion. I'm just identifying this as something we need to think about carefully. So, and this, you see that the plan qualifications are expected to be released in a final format late in July. And then the plans will have 90 days to respond to those final proposed, I guess, because I guess there still could be some changes. And then the qualifications process will start. So a lot is going to be determined by October this year, just in time for our public policy forum. And this is where you see what I already reported on slide 14. I already mentioned that the state has to promulgate regulations before they can designate and really authorize these services. So that is expected to, you know, be released for comment and then finalized sometime in October. So we'll keep you up to date on that process. Here you see when the regulations will come out, the proposed regulations, July 12th to the Mental Health Services Board. And as you know, the slide 17, the designation application has been re-released, but don't expect to hear back because they can't approve you until after these regulations. So Jackie, let's go down to slide 19. Quick review, and then slide 20. Quick review of where we are in children's health home enrollment. I do think that the children's health home enrollment is going better than the adult health home enrollment, so that's a good thing. I think that the changes for the number of kids in outreach is pleasing the Department of Health. There's a downward trend. They were very concerned about too many kids being in outreach. And you see on slide 20, you know, we have about 10,000 kids enrolled in health home. It's a far shot from the 270,000 that was proposed, but it's still, I think people are fairly happy. On slide 21, there's an actual breakdown of the number of kids who are in outreach status. The first slide is outreach. So that breaks down by health home, the kids, the 3,000 kids in outreach. And then on slide 22, it breaks down the 9,000, almost 10,000 kids that are enrolled by health home. And I think here we see that despite the upstate problems with referrals on foster care kids, that Chunny has, a very high number of kids enrolled comparatively. As Hudson River
CCF.
and CCF. Hudson River is doing quite well in the community care. All right. And then I think that, let's just go to slide 24, the last update that I think is of interest to our members. The transition of the OMH TCM to health homes was reiterated, the process and the fact that, DOH thought it was going to happen one way and it didn't, so now we're going to move forward with the reconciliation. OMH staff assures me that there are providers that will get payments retroactively for reconciliation. So they're working on that, and it's agency by agency. It's specific to each particular agency. So stay tuned, but do not be dismayed about the slowness of the process. There is a commitment to reconcile the funding to ensure cash flow stability, which I think is a commitment that's sincere. So the coalition played a role in that.
Yep. And we've been contacted in terms of verifying our numbers, and so I'm sure others have heard as well. So if you haven't heard anything, please contact us.
Yep, contact me and I'll get you in touch with the OMH staff. It has to be done through DOH, but the OMH staff is working on it very carefully. So we have a good friend there looking out for us. And then just the last piece of information, the very last slide, 27. There have been a few providers approved to do early intervention health home management. So these are the programs, including some of our members, who are approved to do early intervention care management. And if any of your members, and this could be another presentation, we could have Liberty do a presentation about what early intervention care management, how it differs from the work that you traditionally do, and then determine whether more providers want to get this designation. If anyone's interested in that, please let me know, and we'll line that up. Okay, so let's go back to our agenda, and we'll give a minute to see if, Nicole, anyone raises hands for questions from the state's PowerPoint for implementation and transition.
Okay. I haven't gotten anything yet, but everyone feel free to raise your hand. I'll unmute you. You can join the conversation. Not getting anything.
Okay.
Okay.
So we'll go to slide 3 on the agenda, on the PowerPoint that we developed for the meeting. So it's very interesting that the managed care organizations meet monthly with the Department of Health. And in the May meeting, the presentation included the fairly final health home measure subset. These are the measures that plans will be reviewing health home operation by, the clinical and process measures. And in the first column, the A and the C is children and adults. So I thought that it was very important that as any of our providers move forward in managed care in general, not just the health home program, that you see what the plans have agreed are the important measures of outcomes and the clinical measures. So you see the first one there, antipsychotic use in children in adolescents when there's multiple concurrent prescriptions. And that's an NCQA standard. And how it will be governed is through the Health Home Serving Children application. And the data source will be administrative. It'll come in through either your CANs or your CARES or whatever data needs to be provided by the health homes. And then the next one for children is the follow-up after emergency department visit for alcohol or other drug abuse, or the follow-up after hospitalization for mental health. And then if you go to the next slide, the follow-up after emergency department, the initiation engagement of alcohol and other dependence treatments, the metabolic monitoring for children and adults who are on antipsychotics, the percentage of and then on the next slide, Jackie, the percentage of members receiving any mental health services, so utilization. They are going to be measuring health homes by the number of children in assignment without outreach and engagement segments. So, you know, I think everyone's heard that the Department of Health is not happy with the children's health home number of kids in outreach, and we can work to, you know, address that. The coalition can develop a position and a policy and explanation about why it happens if people feel that that's important. But just be aware that if you're a CMA or you're a health home, you know, that is going to be a measure that the plans are going to be watching quite closely. So I thought that these measures and outcomes for health home were important. Then there's one more slide, and everyone can look at these, but I thought that this was important because the children's CAG is still meeting, and I would love, Nicole, if David Woodlock or Fern Zager or Audrey or Bill Getman are on the line because they're on the children's CAG, they can be unmuted. But while these decisions are being kind of finalized around health homes serving children, the CAG itself is discussing clinical measures and outcomes that they feel are important. And one of the things that we're going to do at the board retreat on your behalf is to have an in-depth discussion with some key people about how to get everything running kind of along the same track and make sure that there's not communication between and around the same topics among different players. And we'll have Jason Helgerson at the board retreat to talk about VBP and his goals serving, you know, around children. And we'll also have Ellie Ward from the American Academy of Pediatrics, who is on all of these committees, and she actually was the one who said, I want to focus on the fact that the dots don't seem to be getting connected, that there seem to be independent conversations. So I don't know, Fern or David or anyone that's on the CAG, if you want to comment on.
Well, I guess this is David. Initially, I guess I would agree with Ellie's observation that I'm not sure all of these metrics are aligned yet from the various committees and governmental structures that are trying to develop these things. I think the good news from the clinical advisory group anyway is a commitment and an agreement by Jason that the sort of North Star around value-based payments for kids is keeping kids on track developmentally. So I think while value-based payment and Medicaid reform really applies to a much broader group of kids than we typically deal with, including kids with physical health problems and the like, I think a rather significant role for behavioral health providers in helping keeping kids on track developmentally is a really positive pathway, and is really the narrative story worry that in comparison with the adult side of things, where the seriously and persistently ill are high utilizers of Medicaid, are sick a lot, and using ER and inpatient, and the narrative was really about how do we change that metric if and there really wasn't a comparable narrative on the kids side from a utilization perspective, but in terms of keeping them on track developmentally, I think there's a great organizing principle there and a meaningful pathway in value payments. To the extent that that gets then muddied by too overly specific narrative metrics, remains to be seen. But I think that's the job of that group of people, is to try and stay true to that, keeping kids on track developmentally, and then how do you measure that?
Right. So that's why I wanted to bring these metrics to everyone's attention, because, they are well child visits on the last page of the plan metrics, well child visits, adolescent well care visits, but there's really nothing here about what the CAG is talking about, about the developmental milestones that are other than health related. And so that we, the coalition, are going to try to bring those two conversations, together in one place, so that the plans then don't, it's always the kids get mentioned last. So they think that this is the type of thing that they're going to be measuring for kids, and they may have no idea, about the broader discussion that's happening at the Children's Clinical Advisory Group.
Yeah, this is Fern, and I have to agree with everything that David said. We see efforts from a variety of places that are taking similar approaches, but they really are not aligned. I do think that the challenge for the CAG is, as we operationalize the principles that North Star, the developmental milestones, the functional levels for the kids, how we operationalize that primarily through pediatricians, and we bring in the social determinants of health, how true to those principles the actual implementation will be.
Right.
Yeah, and Jason has been clear. We've talked a lot about screenings and pediatricians doing screenings or getting information about screenings that have been done elsewhere, but he wants us to be focused as well on outcomes. So what good are the screenings if they don't tell you what to do, and what you implement and what those outcomes will be? So we're still working on all of that. Our next meeting is on the 10th, and that'll be our last meeting.
Yeah.
It'll be interesting to see what we wind up with.
So we'll get everyone information after the CAG meets about the determinations that are made there, and then after the board retreat as well, we'll, Jason Helgerson, the Medicaid director, will be with us on the 11th, the day after the CAG, to finalize its decision. So it should be an interesting conversation.
Yeah, we'll be literally coming straight from the CAG meeting, at least I will, from the CAG meeting in Albany on the 10th to the Monday evening board meeting. Yeah. It's one right after the other.
Yeah.
Hot off the presses.
Hello?
Hello.
Hi, it's David Goldstein. The other thing I would add to that, I agree with what Fern and David have said as well, but the other thing is the idea that some of these specialized populations, many of whom are the populations we serve, have really been not carved out, wrong word, but set aside for discussions within subcommittees, because it really, a lot of the discussion was around more typically developing kids or more general population. It really didn't apply to certainly foster care and kids in RTFs, kids in community residence, kids that we serve in our systems.
Yeah, we actually set up a committee for complex care.
Complex.
Focus on complex kids, complex care.
So that ties back to my comment that Jason sent out comments on how we can develop programs that are risk sharing, because we really were kind of hoping that the complex needs kids would be set aside for a discussion about no downside risk sharing, because it's such a small N, it's a small population, so sharing risk is dangerous financially. So that's all within the context of what we need to kind of iron out with him if we have the opportunity at the board retreat.
Good.
Okay, so we'll move on to coalition, slide 7. We were very fortunate to have a presentation from Marlene Radigan at the Office of Mental Health, and she heads up their research division. She has been charged with developing databases that will help the adult applicants for the value-based payment. And I say that because OMH really has been pretty clear that they'd like the value-based payment grant, start readiness grants, to go to adult networks that can have kids in them, but they will be robustly around adult value-based payment designs. I do know a couple of our members put in applications, so we'll see what OMH does with those applications. But Marlene, you know, for the first time, Marlene did not do the kids data analytics separate from the adults. She had a job to do to develop databases, and she did it for adults and kids, which is fantastic. So we're not last, finally. And she did a demonstration showing their new platform of data analytics, and we wanted to use the information for our board retreat to figure out what data analytic investments the coalition should be making on your behalf. And the two options that are before us, many of you may have participated recently in the Psyches webinar or earlier this month. And the Psyches division is willing for either individual providers or associations to pay Psyches to do certain reports and run certain analytics. But OMH, Marlene Radigan, is also offering that if we can pay the equivalent of her being able to add staff, that staff time could be dedicated to simply doing reports from the Tableau platform that they are now using. And what she showed us were Medicaid cost center data, clinical data marts, so specific sets of metrics on clinical outcomes related to, and then you could do it by cohort, by program type. She showed us Medicaid expenditure, for example, before and after on track. So we have that first break psychosis program, and she did a cohort sample that showed, you know, the kids' Medicaid expenditures, both health and mental health, before they went into on track, while they were in on track, and after they were in on track. And then just straight utilization data. Her database is robust, and I think it was really an interesting presentation. So I'll stop there and just see if any of the members who were able to attend that quick presentation by Marlene have anything to add. Nicole, you can look to see. I think David Woodlock was on the call, and Jim, and
I guess the only question, I thought the data.
Go ahead, David.
Still there, David?
I've unmuted you.
He was having some phone connection issues, so maybe he just...
Okay.
Well, let me just say that Marlene Radigan is a resource that we need to really utilize as much as possible. I mean, she really works hard to make sure that the data she's dealing with includes the ability to drill down into kids and by age. And so I think this is something that we're going to want to do more and more of as a coalition to support the members, because at the end of the day, it's all going to be about the data. And, you know, it's interesting to me if this is something we can push back to OMH and saying, why do we have to pay for this stuff? You have it. Is there something we can do or something you can do to facilitate it? And maybe it is, you know, getting money assigned or pushed through a coalition to do that. But, you know, it really should be a state activity, state supported.
I think, I mean, I can tell you what Marlene thinks. Marlene thinks that they've kind of shot her budget on developing the new software and buying the Tableau and developing the database, and she just doesn't have staff to be able to do specific analytics, you know, data sets. So I'm just speaking, I'm repeating kind of the discussion that we had. So the whole time that she was doing the presentation, and people weren't in one room, it was a webinar, she was saying, vote for Marlene, which is like, I desperately need staff. Help me be able to do what you need to do.
Right, and so that's why we can really advocate with AMO and advocate with the commissioner and with Donna to try to find resources specific for data reporting.
Yep. So anyone else on the data? We'll get back to the members after the board retreat in terms of next steps. Okay. So slide 8. We were finally able to get an update on the status of what I call the CMS 1038 letter. This is the background bullet, the first bullet here. CMS directed OMH and other state agencies to amend all existing state plan amendments that CMS currently governs to include the details. The way that OMH has always done state plan amendments is that they put in a really vague state plan application, and then they attached the regulations and then referred to the regulations and asked CMS to refer to the regulations as authorization. CMS had determined quite a while ago, I mean, the letter is old, it's many, many, many years old, that the state needed to change all of that and update it. But CMS got so frustrated that the state hadn't done it that basically they said, we're not going to give you any federal financial participation as of October 1st if you don't update all your state plans that are on file. And so the detail that needs to be added to the state plan applications will include service definitions, reimbursement assumptions, and all staff requirements. So OMH has successfully negotiated almost to conclusion the children's day treatment rewrite and the PROS rewrite. And CMS understands that they'll need time to plan and prepare for changes. But, you know, we hope to hear the final, whatever is going to be required of day treatment. They are very optimistic at OMH that CMS will allow it to the retained monthly billing and the reimbursement assumptions for day treatment and for PROS. The only change that they are anticipating for day treatment is that CMS felt that the authorization to do off-site visits under children's day treatment was in violation to, you know, their reimbursement rules, and so that will probably be eliminated from continuing day treatment going forward. So that's the update on day treatment. Now, if you go to slide 9, there's a little bit different story for community residences. There are 300 children's community residence beds around the state. There's 1,000 adult beds. Both will be impacted by the rewrite. The current documentation requirements are 4 15-minute services and monthly billing. And CMS agreed that that does, while that does decrease administrative burden, they don't feel that it gives them enough ability to, review the number of services or the value, within the services that are provided. So the plan is that OMH will submit to CMS the existing CCR SPA fleshed out with all of the details. They expect that CMS will reject that we'll have to move to a daily rate for children's community residences. OMH will ask for a 12-month design and transition period. They will ask for different rates for children's community residences than adult community residences because of the model differences. And they suspect that to get this submission in soon, like by the 1st of July or by the first week in July, and that there'll be a 4-week window for CMS to respond. So we should know, by the time we meet in September, whether the changes that OMH thinks are going to be required are the scope of what CMS requires, or whether there's a more hard line. But the request for the transition period will specifically be intended to circumvent not jeopardizing the federal financial participation for children's community residences. So I will stop there and see if there are any questions.
Andrea, this is Jim. I just want to reiterate that we know that for 15 of our members, this is very important. So it's very important to us, and Andrea will stay on top of it and will certainly continually ask if there are any questions and get your feedback as this continues to move forward.
Andrea, it's Lenny Rodriguez.
Hi, Len.
Hi. Just a question about any sense in terms of the rates when you mentioned that they're, obviously they're moving towards the daily rate. What difference compared to the adult rate are they thinking of, or is that information not available?
Well, I think that they, we have built in either formally or informally different staffing patterns for the kids' community residences. They want to preserve the fiscal viability of all the existing providers, so they want to make sure that when they negotiate the reimbursement methodologies and how they're described, that both the formal and the informal agreements around the staffing patterns are captured. That's always a problem with OMH. Sometimes they help us and it doesn't help us in the long run, right? But
right.
There's a commitment for them to codify those rates, those staffing differences, so that the rates will reflect, the adequate staffing that we so hard fought, the coalition hard fought battle to make sure that the staff was there for the kids for after school periods and vacations and summertime and, all of the things that we have gotten in. And I don't think that there's a CMS intention to negotiate rates down. I think it's just a question of, as they review what we do or what we put into writing versus what we were doing, that it doesn't open up a broader array of questions, if you can understand what I mean. We don't want to bring down audits on all children's community residences. The state mentioned something about their exempt income rule and the fact that they would like to get that written out of the regulations, but it's in statute, and so that one's going to be a little bit tricky.
Right. Okay, thanks.
Yep. And we'll, you know, I on the RTF provider call yesterday, I promised to create an interactive listserv so that as we do talk about the RTF pilots amongst ourselves, you know, people can respond instead of just the constant contact. And as we get further along on the community residences, I will do that for the community residence agencies as well, so that we don't have to always wait till a formal meeting and people can be communicating on a regular basis.
Okay,
Which
thanks.
brings us to slide 10, which is an update on the RTF pilot. OMH released an informational survey earlier this week, I think. They didn't give providers a really long time to respond. The response date is July 7th. Jackie, you have this document if you want to put it up on the screen so that non-RTF agencies can see, you know, just kind of how basic the first step is in the RTF pilot progress. So OMH's goal is really to support RTFs that have not been maintaining full census in their RTF bed and allow them to get some funding to test out alternative services that are appropriate for high needs kids. So there's the glitch. I think that's the biggest divide in this assumption, in this pilot. It's good that we're trying to figure out a way to hold RTFs harmless as they start to determine whether there's a downsizing appropriate in their future. But, you know, from the coalition's perspective, we have to take two other things into account. One, the fact that the home and community-based waiver program, as it moves to 1115, is going to water down the intensity of the home and community-based waiver program. So if OMH wants to defend the fact that RTF beds are underutilized because we've expanded home and community-based waiver and these kids are being served in the community, they also then cannot make the argument that as we reduce the intensity of home and community-based waiver and move towards a health home model with higher ratios and less coordination in terms of it not being the same person doing the intervention, you know, that high needs kids may not be appropriate for that less intensive health home model of home and community-based waiver. They may not respond as well. Families may not feel as supported. We don't know, but I think that that's an important point to keep in mind as we go through these pilots. And then the other, you know, I think important consideration is that if there are Medicaid cuts in our future, there is no doubt that RTFs will be looked at because they're the highest cost service. So here we have an opportunity to figure out if there's a right sizing or more intensive services that really help kids that otherwise would be in an RTF. And the pilot is going to give RTFs two options. Tier A option would be to reduce beds temporarily, reduce staff, and then get that equivalent amount that would be saved back in grant funding, no Medicaid rules, to be able to test out innovative services. They could be the 6 new state plan services before they're approved. They could be a crisis residence or respite service that is in the adult home and community-based waiver model but wasn't included in ours, but OMH is committed that if it works out in the pilot and it's something that really is helping kids, that they would then, you know, try to add it as a benefit for kids. You know, expanding partial hospitalization in the community instead of RTF beds, or, and we'll go into more detail on the ILP, combining an overnight crisis bed with intensive clinic services where a child could be going to clinic getting 3 or 4 services each day for 3 or 4 days out of the week, to really address like medication management, crisis de-escalation, working with the family for stabilization at home. So that's tier A, getting state money without Medicaid rules to test out some of those other services in innovative ways. And then tier B, which wouldn't be OMH's first step. If agencies choose, if RTFs choose tier B, the determination about whether those pilots will go forward and how they'd be reimbursed will happen after all the tier A decisions are finalized. I think that's because their preference is to spend the money on tier A and to show savings to test out the models, whereas tier B, it's not going to be a dollar for dollar like investment, so to speak. You're not really going to save money on shorter length of stay or enhanced wraparound or family engagement. Those are more like you need grants to do those things, to be able to accomplish those things. So I think they're being conservative in making a commitment about what money would be available for the tier B pilots. So I'm going to open it up to see if anyone else, who was on the RTF webinar or was on the coalition call yesterday has anything to add about how I've characterized it.
Andrea, it's Lenny again. Can you hear me?
Yep, go ahead, Len.
Just a question. I'm sorry I missed yesterday's call. So just to be clear, because there was for some people, confusion or lack of clarity. The tier B does not require a reduction in bed capacity, which is also another reason why probably OMH is not so invested as a first priority. Is that correct?
I think that the sense is there could be bed reduction put up, but say you're a 14-bed RTF, and Zig Malawicki was asking this question yesterday. Say you're a 14-bed RTF and you want to focus on, shorter lengths of stay and better, handoffs and discharges and quality with family engagement. So you figure with reduced length of stay, you're going to be able to put more kids through. You haven't been able to maintain your census. So you're going to say you're going to turn in 2 beds. Well, turning in 2 beds doesn't help you fill out this form that we're showing, which says how much are you going to save on staffing your unit? Or how much is it going to reduce your operational costs if you close 2 beds? And so I think that what I'm saying is I don't know that they would take 0, but I think they understand that there's no real savings up front, so they would just be taking whatever residual funding they're able to make available to the tier A pilots and then applying it to some tier B grants. I don't think that this would be a lot of money. Does that answer your question? That's my interpretation of what they're thinking. Yeah.
Yeah. The other bunch of questions, I don't know if there's any information on it, is for those that have more than one RTF. Are they treating each RTF separately? Do you provide a number for the number of beds you have and then use the money accordingly? There's still a lot of clarity that would help inform the decision.
Right, and I do think they intend to do it RTF by RTF. So you could run a different pilot, at one RTF that you operate than you would at another one, and the funds would go to operate that pilot. It's not going to be a melding of funding across RTFs, even if they're at the same agency, which I think is a protection to your own cost reports. I mean, I think that we want to make sure that whatever's done temporarily doesn't screw up our rate methodology going forward.
Right. And the last question is, I thought that Emil did say in our conversation that it was a full reimbursement. I mean, when they were looking at it, after you do all the math, they were talking about both the state and federal share, right? They weren't just talking about monies, the state monies.
No, they're definitely going to make you whole on both sides. So it is a, you know, a dollar for dollar intention that you would end up with the same revenue that you would have if you were operating the RTF. And I only hesitate there to say, I was going to say full capacity, and I don't know how they're going to do, you know, how they're going to calculate the empty bed issue. I think that the intent is to give you the full operating cost of each individual bed, regardless of what your census has been.
What do you mean you don't know how they're going to calculate the empty bed issue?
Well, I mean, I don't know if they're going to get into a fine-haired negotiation with you where you say you're going to close, you know, temporarily reduce your PAR to close 8 beds. And they're going to say, well, 6 of those 8 beds weren't really open, so we'll give you money for 6 of the 8. You know what I mean? They, you know, because you weren't at full census. I'm projecting. I have no idea if they would do that. I hope they wouldn't do that, but, you know, we just have to, as we get into the details, we need to make sure that you're getting the full value of your operating costs in the grant.
Exactly. Otherwise, what would motivate some of us to do it? If they're going to, you know, take that position, then again, they're turning the tables to the providers and saying, well, you continue to keep absorbing your deficits, and we're only going to deal on top of that. And that's just not, I don't think that's really very collaborative and collegial, or I would have an issue with that and I think we would as a provider, and I don't want to speak for other providers, but I know that others would probably feel similarly.
I agree, and I'm only speculating. I keep hearing the challenge of making sure that they don't commit fraud on the cost report. You know what I mean? I think that there's just some technical issues behind the scenes about how they're going to reduce these PARs and keep our rate hold our rate methodology harmless. So that, I think, is the rubber hits the road, real negotiating point. No reason to go into it now, because the intent is to make you fiscally soluble as you test out, you know, a world in your community, with your community. I mean, engage the families, engage the county. You know, people rely on these RTF beds, and, you know, there are not everyone wants RTF beds to be downsized. So it is a good PR approach to make sure that everyone understands this is a temporary reduction in beds, and the intent is to replace it with services that help kids in the community.
Okay, thank you.
All right, if there's nothing else on the RTFs, then we'll have lots of calls just on that issue. And we'll also get a lot more details at the board retreat. Emil and Donna are both coming to spend some time with us at the board retreat. So we'll go to slide 11. Again, I really appreciate the fact that our members did make calls. I have gotten a lot of positive feedback from Senator Orr's office about the support, that people did call in to try to move that timely payment bill, Senate 6219B. It passed the Assembly. It did not pass the Senate, as is the case with almost all bills that have to do with insurance. And that might have to do something with the fact that Blue Cross Blue Shield pays Hinman Straub $450,000 a year to lobby for them, but that's a detail that people may not know. So Senator Orr was committed and even scheduled a meeting for the behavioral health advocates to come in and strategize a way to get the timely payment bill on the agenda when the legislature came back. So unfortunately, the governor kind of preempted that because our meeting is on July 6th and the special session's today. I don't think that the legislature is going to do what the governor wants today. They have to come back when he calls them back, but they don't have to vote on the bill. So we have some opportunity to still consider this depending on what happens today. But that bill would have required that plans can't tell you that it takes 6 or 8 months for them to update your software when they're supposed to increase your rate, you know, because we got a law passed or we negotiated a rate increase. They have to pay you as of the date that the change goes into effect. And that would have been in statute, and you wouldn't have to have worried about the fine print in a contract about retroactive payments and all of the things that happen when you enter into contract with managed care organizations. And we really, really wanted that legislation signed into law. So we'll be back on that. The one bill that did pass both houses that many of you who work in the early child mental health field is that a bill that requires a maternal depression treatment registry where plans have to include a list of providers qualified to address maternal depression and make it available to all of their members. It's a little bit different from including them in your network, but it's a good first step that pediatricians will have to know if they screen for maternal depression and the screen is positive, who to refer those mothers to get maternal depression treatment. So I thought that was a very positive piece of legislation. And then the bill that, if anyone in the Capital District watches Capital News Tonight, the bill that I was on the television show for the last night before the session ended, which was that a bill that would have allowed other licensed professionals to be assigned Medicaid numbers. This really has to do with accessing services. You know, our health homes are struggling to refer kids to services. I mean, if there are licensed family therapists and licensed mental health practitioners that want to treat Medicaid eligible kids, it just doesn't seem right that they aren't able to. And then, you know, when we discharge kids from high-end services and licensed mental health professionals work for us at our agencies, and they might want to take a kid when they go back onto commercial insurance in their private practice and continue working with them, that might be an option as well. Or if the child is community eligible for Medicaid, that they would continue, there would be a continuum of care. So that's just a workforce issue. We have severe shortages. We're not going to solve the shortages by getting more people to work at our clinics. So I spoke in favor of that legislation. It did not pass the Assembly. It did pass the Senate, so go figure that one. I'll get a more robust summary out, but those are the bills that we were working on towards the end of the session. And the last item is a notice from OMH that went out June 6th. And I apologize because it's June 28th and I only heard about this on June 20th. So usually I'm on top of these things and I get this information out to you. I'll get the guidance document. I think Nicole actually sent the guidance document with the meeting notice. All of the PowerPoints and documents that we put up on the screen today are available in attachments. But the Office of Mental Health has announced that they're going to make $1.25 million available to help licensed Article 31 clinics create a new intensive level of outpatient service. The IOP level of service will be for really concentrated treatment through the clinic for people in crisis. They want to help the clinics with a startup and provide one-time $25,000 grants to 50 different clinics and make these services available within the next 3 months. So as I described in the RTF pilot, you know, are we trying to create a replicatable short-term intervention for certain kids that could avoid hospitalization or even longer RTF stays if there were more intensive services available to them right away at the beginning of their crisis? and combining some kind of crisis bed or therapeutic crisis service with this IOP level of care, because the child wouldn't be still going to school, they're in that much of a crisis. You know, a couple of weeks of really intensive medication titration and crisis therapy through the clinic, you know, it combined with a safe bed during the medication titration and out-of-home placement in a crisis bed, you know, does it start to move towards something that our community and families could benefit from? So we'll get the guidance document out and try to help answer any questions. I did ask Lisa Clark at OMH to give me a briefing about how, you know, the 50 clinics, you know, what the criteria were. It's very vague in the guidance document, but I will share any information that I get back from OMH as soon as I receive some kind of briefing on it. All right, so with that, we will open it up for any other business. Suggestions about what else we might want to take up at our board retreat, of course, are always welcome from the members. Any news that I may have missed, if Astra's on, how the OMIG audit of the waiver program went. People are on the edge of their seat on that one. Or anything else that members want to raise with the coalition.
If folks raise their hand, I can unmute you. Nothing yet.
Actually, I'm just going to report that Lisa Clark got back to me. She is concerned that the IOP model might be clinically difficult to implement, but she would be happy to review any models that people, individual clinics, want to try. She would be willing to let people bounce them off of her, and she'll take a look at it and then give you a fiscal analysis of whether or not your thoughts would work. So anyone that is thinking about the IOP clinic grants, get in touch with me, and we'll set up a time for you to talk to Lisa Clark at the Office of Mental Health.
Andrea,
yes.
Do you think in the pilot, if we recommended or suggested an IOP alternative to hospitalization, that they would be open to looking at savings related to reserve bed day costs? Because that's really what we're saying, is that instead of sending a kid to the hospital, we could keep them in a more intensive day program, and it would save on that reserve bed day.
I don't know about the reserve bed day, but the thing that I'm thinking is that why wouldn't you want, in your RTF pilot, if you say you want to test out IOP combined with a crisis bed, you don't have that financial risk that Lisa's talking about, because you can provide the service through your clinic and just use the grant money and not bill Medicaid. So you could kind of test out the fiscal model of providing the service without having the Medicaid restrictions, which could inform, you know, what the actual cost could be going forward. That's just my initial thought. I don't know about the reserve bed days. All right, if there isn't anything else, we finished early despite starting late. And I'm always available for any questions that people might have or follow up.
This is Jim.
Great.
I guess I want to thank Andrea and Jackie on behalf of the membership for really continuing to work on our behalf. I think, we had a successful budget year for us, even though some of those legislative items did not come through. I think more importantly is at the board retreat, we have a fairly high-powered agenda with Jason Helgerson attending, Emil attending. So I think there'll be some opportunities to really have in-depth discussion. So if you have any thoughts, please send them to Andrea, because I think this is an opportunity for us.
Oh, Jim, I just want to mention one other piece of news. Martha Schaefer-Hayes, who has worked at the Office of Mental Health in various capacities for 30 years, is retiring. And the good news for us is that Emil is not going to become the exec dep commissioner. He wants to remain in the job that he's in. I think that's very good news for us. So the expectation is that Dr. Chris Tavella, who is in charge of clinical, the commissioner for clinical services, will become the exec dep. So I'm glad Emil's staying put.
Yeah, he's been a supportive for us.
All right, thank you very much, and everyone have a safe and happy 4th of July weekend.
Same to all of you. Bye-bye.
Bye-bye.